Welcome again. My name is Alessandra Schneider. I'm a senior program manager at the International Step-by-Step Association, and I will facilitate the webinar today. We are meeting for the 6th time under the Health Systems for Early Childhood Development initiative. It's a joint initiative led by the UNICEF Regional Office for Europe and Central Asia, the World Health Organization Regional Office for Europe, and the International Step-by-Step Association. I want to share some technical information with you. So we are providing translation into Bosnian, Croatian, Montenegrin, and Serbian, or BCMS, and Russian. Please choose your preferred language by clicking at the translation, the interpretation box at the bottom of the Zoom page. Remember to write down your questions or comments in the question and answer or chat box, and you can do that during the presentations. So we are privileged to have in the opening session two distinguished colleagues. So we have Dr. Martin Weber, who is the team lead at the Center for Quality of Care and Patient Safety at the WHO Regional Office for Europe, and Dr. Mihaela Ionescu, Program Director at the Step-by-Step Association. We will start with Dr. Weber, please.
Hello, everybody. Dear colleagues, it's a pleasure to be with you today and to welcome you on behalf of the World Health Organization. As it was said, I'm the program manager for child and adolescent health, and at the same time, the team lead for quality of care in the European Regional Office of WHO. As most of you know, because it's not the first time you are here, this is a partnership between the three organizations, UNICEF, ESA, and WHO, and it's a very valuable knowledge platform which we are having here. As we are moving the agenda of early childhood development, we try to cover different aspects. You have seen already our baseline materials, and it's really a pleasure to see Ilge Ertem here, who has been the lead on early childhood development for this pocketbook of primary care for children and adolescents, which we have put together over the last 5 years and which we have presented already in one of the previous sessions. So you know about the content which we want to promote in the European region, where we believe that every child, when they see a health worker, should be monitored, assessed against, and promotion messages should be moved forward. We know the content. Now we need to talk today about how do we get it to the health workers. We know from previous assessment exercises that many of the health workers don't know what to do. They are afraid of younger children. They are afraid, more afraid the younger the children are. And obviously, we have to try to empower them not to be afraid, to do the right steps and to do the assessment properly. Many times we move into in-service training because we are impatient to move everything. In-service training is very important, but to make the approach sustainable, we have to be in pre-service training. In pre-service training for nurses, for community health workers, and particularly for doctors. And we need to decide what should every doctor and nurse know and what is specialist knowledge, which a pediatrician or particularly a specialist in developmental pediatrics needs to know. And these sectors need to interact. So we are in a good way today to move forward on these agenda points. Dr. Ilgi Ertem is going to give us the background, and I'm particularly intrigued then afterwards to have the 4 country examples, how countries have been dealing with these issues. Welcome again from the side of WHO, and back to Alessandra with this.
Thank you so much, Dr. Weber. And now we are listening to Dr. Ionescu, please.
Good morning and good afternoon, or even good evening to everybody today. On behalf of the International Step-by-Step Association, I'm very honored to welcome all of you today to the webinar organized under the Health System for ECD initiative in a wonderful partnership with the regional offices of UNICEF and WHO Europe and Central Asia. The initiative, as perhaps many of you already know, or those of you who don't, will learn. It's a platform for learning, for advocacy, for exchange, to support practitioners, experts, and policy makers likewise in their efforts to build health systems that address child health and early development in a holistic way. We know that science tells us that early childhood development is the result of the interaction between the environment and the child. Well, the most important and proximal element in the child's environment are the primary caregivers. And a nurturing environment is created by a caregiver who is sensitive to child's health and nutritional needs, provides protection from threats, opportunities for learning, and interactions that are responsive, warm, emotionally supportive, and developmentally stimulating. Well, health professionals have a continuous contact with parents and primary caregivers before and after child's birth. Thus, if they are adequately prepared, the health professionals can use many entry points to support caregivers in establishing that kind of nurturing environment and delivering an appropriate care to their children. The entry points, we may very well know, are the prenatal care, the child's birth, the postnatal care, the outpatient well and sick child care, nutrition rehabilitation, and pediatric care. Health promotion and nutrition information management, as well as surveillance and monitoring, are frequently tackled in the professionals' training, of the health professionals' training. However, how to support responsive caregiving, protection from threats, opportunities for early learning at home and since birth are usually the missing components of the nurturing care approach in the preparation of the health professionals. Today, we tackle critical elements regarding the professional preparation and the continuous capacity building of the healthcare workforce that is aimed at supporting caregivers to provide children with nurturing care. How we can strengthen the competencies of healthcare practitioners via pre and in-service training and supervision to guarantee that the nurturing care informed practices are conducive to child's healthy early development, and they are embedded in their daily practices. What are the opportunities and barriers for partnering with the higher education institution, as Dr. Martin Weber just mentioned? How can we partner with the higher education institutions to add new content to the undergraduate and postgraduate courses? How we can benefit from different instructional approaches now that we have learned, it's not just about the face-to-face learning, it's also the online and remote learning or blended medium ways of instruction, how we can make them more effective in the learning process. These are some of the questions to which we will plan to answer today, either by listening to well-experienced, and we're happy to have her again in our webinars, Dr. Ilgi Ertem, but also from the countries that will be presenting today. A qualified health workforce, be them doctors, not nurses, midwives, or other health workers, with acquired up-to-date competencies on early childhood development and on how to support nurturing interactions is essential for achieving the developmental outcomes to which all children are entitled, and also for improving the quality of the healthcare services. So on behalf of our partners, I would like to thank in advance to the invited experts from Turkey, Turkmenistan, Hungary, Italy, and England, who have kindly accepted our invitation to share their experience in pre and in-service training and supervision. And we hope that they will serve as an inspiration and guidance for many of you, as we saw that you are joining us today from many corners of the world. A fruitful webinar to all of us, and thank you for choosing to be with us today. Over to you, Alessandra.
Thank you so much, Mihaela, for your inspiring words. And now we have one more distinguished expert in the field that I'm very honored to have here, Dr. Anne de Guttner, who is the Secretary General of the European Academy of Pediatrics. Please, thank you for being with us, and the floor is yours.
Hello, good morning.
Oh, hello. Thank you so much for being with us.
I am very, very sorry for the technical problems. Can you hear me now? Okay. Okay, so on behalf of the European Academy of Pediatrics, which I'm presenting, and also the European Board of Pediatrics, which is responsible for the education in Europe for pediatricians, I feel very honored to be here because this is the most important topic in pediatrics, that's early childhood development. Because we only know that it plays a pivotal role in shaping the future of individuals. And if parents think of the future of their children, they think on a long term, they think on a good job and a happy life. But actually the future starts at the very, very early part, even in before conception already. And the first few years of a child's life are very crucial for their cognitive, emotional, and social growth. We all know that, but we know also that genetics lay a foundation, but nurturing environment, it's essential, that provides the building blocks. And during early childhood, all these neural connections are formed at an astonishing rate. And these early experiences, you all know that they influence the architecture of their brain and they affect lifelong learning, behavior, and health. And as primary healthcare workers, nurses, pediatricians, general practitioners, we really need to have the tools and uniform tools to address parents and help them in these early life with their child. What we are facing often are language barriers. What language do we use in early childhood development? And with language, I also mean, as we have the ACEs, the early childhood experiences at this moment, we do feel that we need to train pediatricians much more in using these universal languages. And also the European Academy of Pediatrics, we know as pediatricians, we have the children with the complex care needs also. We address that language problem too, because complex care needs, we often think on complex care medical needs, but complex care needs, we now change to complex care and integrated care needs. And that integration, that working together, all these health professionals with parents, educators, other caregivers, we will need to work together. I'm so happy with this initiative that we bring people together. Proud to be there for EAP, and I wish you all a very, very important, interesting Congress. This is such an important initiative. Thank you.
Thank you. Thank you very much, Dr. Anne, Mihaela, and Martin, for your great opening remarks and continued support. Now I have the honor to invite Dr. Ilgi Erten, who is a professor at the University of Ankara, founding member and member of the executive board of the International Developmental Pediatrics Association in Turkey, for our first presentation. And Dr. Ilgi will present strengthening healthcare practitioners' competencies to support nurturing care in early childhood development. Please remember that you can write questions either in the question and answer or in the chat box during her presentation. Dr. Ilgi, the floor is yours.
Thank you so much, Alessandra. Thank you to the WHO, to UNICEF, and to ISA. All dear members are here, and I am seeing so many people I know, and hoping that I will know more and learn from you in this webinar. So I'm going to share my screen. I hope, can you see it? Is it okay? And I hope that it will be moving. So please let me know if it's not advancing. So we're talking about strengthening healthcare practitioners' competencies to support nurturing care and early childhood development. And the opening speakers have very briefly but very eloquently, they have told us what this is really meaning for our health systems. I want to start by showing you two photos which really speak to what we are talking about. Here is a mother. This is both are from Turkey, photos. This is a mother of a very sick child with many medical complex needs, but also psychosocial needs, as Dr. Gutanare has pointed out. And yet, in her hospital bed, this little girl is getting, you know, nurturing care. We can see it from her mother, who is very inexperienced, very young, as you can see, and also very undereducated. So this can happen. Another little boy at home, you don't see the mother, but you see that she is here, and the parents are actually, the father is in the room, and this is a little boy with Down syndrome getting a similar kind of nurturing care in his home. So what do we need to do as healthcare providers to make this happen for all children? We know that the healthcare system is really the only system reaching children in early childhood. These children do not have a teacher, or not everyone has a social worker, but everybody has a primary healthcare provider, whether it be a physician, it can be a nurse, it can be a home visitor, a home visiting nurse. So we do have healthcare providers who see children from even before they are born, even prenatally. So they are in constant contact and in continuous contact with families. And but what do healthcare providers say in all of our countries? They say we don't have tools, we don't have training. They also say we don't have time, but I will leave that out to be discussed later, because time, providing time for our patients, for the families that we see, is often not in our hands, but the tools and training is in our hands. And the last one, the time issue, we need to advocate for with policymakers. Now, why do we not have the tools? Why do we not have the time? Let's look at medical education. We know that development to optimal potential is the right of every child. So there's no question that this has to happen. And we are reaching these children and families. But what are we teaching in our pre-service programs? We're teaching a lot of anatomy, a lot of pathology, a lot of cardiology. When I say pathology, not just the pathologization of illness, but we're teaching people to look at a cell and know its organelles, and to know whether this is a colon cell and even a colon cancer, whereas they're probably not even going to see a microscope in their lives. Of course, we have to teach the foundations of medicine and healthcare, but we are not teaching them the foundation of human development so that they don't even know when they graduate from our nursing schools or our medical schools, how am I going to look after my own baby? How am I going to promote, to support the development of my own child? They don't know that. So what do we need to do? What is it that we need to empower them with? We need to apply theory and science. So theory, as Mihaela very nicely pointed out, is in the bioecological theory by Bronfenbrenner, which we have schematized here. The child develops not in a vacuum, but in his family, with relationship. And we must be within that relationship. Healthcare services stand the closest when children are young to this relationship. And where is the science? My background is in developmental pediatrics, which has taken on the science of incorporating child's development and disability into the health system. So we need to take from this theory, take from this science. We need to apply a roadmap. And the WHO and UNICEF have brought the nurturing care framework, which does provide actually a roadmap and a content for what we need to be doing. The pocketbook of primary healthcare for the region, which Martin has talked about, is another very important roadmap that we need to have in front of us. So, but what are the components of nurturing care that are particularly difficult to teach in our systems? So our pre-service students, I'm going to say, trainees, know about health, know about nutrition. They know a little bit about security and safety, not so much, but opportunities for early learning and responsive caregiving, those are two big concepts that are not in our curriculums. So what do we need to equip them with? We need to equip them with knowledge, skills, but also attitudes. And this is the hardest part to achieve. And what are the attitudes we're talking about? It is to partner, watch, and enjoy supporting children's development, not to be like I'm going to call it a dictator and say, you know, you do this to your child, or have you done that to your child? So that's not the attitude. It is the partnering attitude, the enjoying attitude that we need to be able to attain. Witnessing, mirroring, and enhancing strengths of children and communities. I'm going to run through this with larger slides. So partnering with family and watching and enjoying. And the photos I'm going to use are going to be from our region of work actually happening, so that we have a feeling for, yes, this can happen. It doesn't sound, it's not just an idealistic thing that we're thinking about, it can happen. And supporting individual development, not just saying the same thing for everybody. It needs to be strength-based, witnessing, mirroring, and enhancing strength of children, caregivers, communities, in supporting early childhood development. You see a beautiful photo from Turkmenistan. You know, you see the whole family there. They're having a meal and playing with interacting with their children, the mom and the father. It needs to be risk-focused. We need to be able to identify, address risk factors and developmental delays. So developmental delay, I view that as just another risk factor, but maternal depression is a risk factor, or paternal depression is a risk factor. Prematurity, as you can see in this photo, is a risk factor. Chronic complicated illness, even if not complicated, chronic illness is a big risk factor. So we know that at least 15% of children are going to have delays, and at least 30% are going to be at risk. So just identifying is not enough. No service, no tertiary, secondary, tertiary service is enough to take care of these children. So this has to happen in primary care. It needs to be, what we teach our students needs to be participation oriented. So we need to aim for not building, Legos or blocks or not rote learning. We need to get families out into the community with their young children, out into nature, which is where they can learn most. And we need to be able to include all children, including those with difficulties, in every way that they can participate in life. It needs to be service linked. So we need to be able to teach our students or trainees how to guide families to how to choose those services, appropriate, accessible, evidence-based, family-centered, so that in a service like this in the photo, can you tell who's the parent, who is the physician, who is the developmental pediatrician, who is assessing and providing intervention for this child, who is the early childhood specialist? You can't really tell. So it needs to be that close, that amount of partnership needs to be built. It needs to be needs-based. So advocating for needed resources that may not exist in the community. We can say developmental pediatricians like this fantastic one who is serving in the East, in the earthquake region right now. Maybe they don't exist. Maybe they don't exist, but we need to advocate for them. Maybe we don't have libraries for young children in our communities. We need to be able to advocate for them. So the army, I'm going to say, of these healthcare providers who are going to graduate needs to be indoctrinated with this. Now, I'll just bring an example because I know that you are all wanting examples and we will hear from the country examples. But this is a multi-country example that we have used to accomplish these things. The program is called Addressing Developmental Difficulties and Early Childhood Development. So ADD-ECD is our acronym for this. It is a cascading south-to-south collaboration model. It aims to prevent on the prevention, early identification, and early intervention for children, for young children. It is sharing the science of developmental pediatrics with regions and the countries that do not have it. And it has been supported by numerous stakeholders, including UNICEF, WHO, Ministry of Health, NGOs, academia, all levels of healthcare, and families and children as well. So this was, the model is shown here. It's a photo done by my colleague, Dr. Revan Mustafa, and it took place from Turkey to Azerbaijan to Turkmenistan and then Kyrgyzstan, and there was a cascading type of training that was going on in these countries. The tool that we used was the Guide for Monitoring Child Development, but there are expanded versions of it that we use in this ADD-ECD program. So the step one of this was convincing the countries, right? So countries, UNICEF was key in this and brought together representatives from countries. Here you see Sachli, much, I'm going to say she looks the same. I don't for sure. But this is her little daughter. So it was many years ago. And you see her acting in a role play. And you see other participants from the countries, Turkmenistan, Azerbaijan, other countries were also here, and they came to observe our developmental pediatrics units in Ankara, and also gain some expertise on what they would be going and looking to achieve. Step two involved training of international trainers, because language, yes, we don't all speak the same language in terms of content, but we need local language speaking trainers. So I trained these two, Dr. Terane and Dr. Revan, two Russian-speaking developmental pediatricians who could go and train in the Russian-speaking languages. This can be done for other languages that are common. And you can see their method of training. It's really modeling. It's really fun, interactive, and very humble. The trainers need to be extremely humble in what they're doing. The step 3 is training of country trainers. So this is the more difficult part, but choosing the right trainers is really the key in this. And it involves a lot of interaction and a lot of experiential learning. So what has happened in Azerbaijan and Turkmenistan 10 years later after this was started? We know that, you know, things are not great and we could go into barriers and facilitators, but we know that in the end, there are local trainers that can train the workforce. There are ECD services that are scaling up. There are, although few, developmental pediatrics and pre-service curriculum and in-service proficiency assessments. I'll just take a moment. I know my time is up, but I'll just take a moment to talk about the math of pre-service training. So when we are talking about pre-service training, we are looking after what is pouring into the workforce. And not only that, but pre-service training means that we are working with young, energetic, enthusiastic, humanistic students. There is a math of this pre-service training. I'm just going to run through it. We graduate in Turkey 15,000 medical graduates per year. We've been advocating for inclusion of all that I've said for 28 years. Ideally, 420,000 students would have been trained, but in actual fact, because it was only happening in 2 universities, Ankara and İnönü University in the East, only 5% were trained, all of the students in those medical schools, but only 5%. And what would it take to reach the whole country? Not a lot. 2 trainers per university, 12 hours of the 9,600 hour curriculum. I calculated this morning. I feel like math is my strength and I love numbers. So that is how little it takes out of a curriculum. And what is the lesson learned? And that is, don't wait so long. I want to end with photos of my beautiful students. I miss them a lot, and I hope to be with them in some shape and form for years to come. Thank you so much.
Thank you so much. Thank you so much, Dr. Ilgi, for this very inspiring, excellent presentation, and for keeping the time as well. I appreciate that very much. So let me see, do we have any questions from participants, from our participants? Not yet, I think. So shall I have a question. I have many questions for you. But Dr. Ilgi, so according to your extensive experience in developmental pediatrics, how can professors or senior professionals teach students or junior colleagues, junior practitioners, the key skills and attitudes that you just mentioned in your presentation, such as observation, how to respond in a responsive way to parents, because you described that in addition to the knowledge, we have to teach this kind of soft skills, right? And what is your experience on teaching that, and what would be your advices on that? Thank you.
Thank you so much for this great question, Alessandra, one that is very dear to my heart. So in fact, developmental pediatrics is a subspecialty, which actually would be ideal to be teaching this in the pre-service. But how do you train developmental pediatricians, right? So that's the big key question. So in some countries, including Turkey right now, it's a 3-year fellowship, but that's a very long time. We can get there, but I know that that's not where we're starting. So the model that we have used is very short-term training of the right people, choosing the right people, and then using the right tools and the right package to train them in. And these would be the senior or mid-level, even junior faculty members at medical schools, nursing schools. It can be done. The package is very comprehensive, and it is a similar package that they would apply to their trainees with the same philosophy that you're talking about. A very compassionate, humble trainer. It trickles down to the trainer's attitudes, to the trainee's attitudes, to the family, to the child. So that's the same kind of attitude that we want. And when we talked about family-centered, strengths-based, all of that is included. It is doable. I've seen it happen in my country. I've seen it happen in many countries. If you choose the right kind of people, you can do it. But you cannot do it for a mass of, let's train, 50 trainers. No, that doesn't happen. But if you choose people with these qualities already in place and with some, of course, extensive knowledge of pediatrics, then you can do it in a short time.
Okay, thank you so much. And we have one more question for you from Liana Gant, ISA's executive director. She asks, who were some of the allies in this effort of advocacy and who were hardest to persuade?
Okay, thank you so much, Liana. Allies were, of course, as you saw with my numbers, it was not persuasion did not happen. Okay, so only 5% is what we're reaching. But allies were UNICEF. UNICEF was a big ally. Some key technical people from Ministry of Health. Of course, this ministry changed many times. It's interesting that our efforts, our push, our advocacy remains the same, but politics changes. So ministers and ministries changed many times. Academia, some of academia was ally, some of academia was opposing, was saying, no, this can be done by neurology, it can be done by social pediatrics, whereas development, the science of development, is different. Okay, so you need to be able to equip whoever it is. Yes, it can be a neurologist, it can be a neonatologist, it can be a general pediatrician, but you need to equip with the science of development.
Okay, thank you so much again. And now we will move on to our next block. So now we will learn about country experiences of pre and in-service training designed for healthcare practitioners to strengthen their capacity to support caregivers to provide nurturing care and promote early childhood development. Our first presenter is Dr. Maya Ananurova. I apologize if I did not pronounce correctly your last name. She is the head of the Department of Pediatrics of the postgraduate education of the Murad Kariev Turkmen State Medical University in Turkmenistan. Please, Dr. Maya, the floor is yours.
Good afternoon. I welcome all the participants of this webinar. in Turkmenistan, the protection of mother and child is a key priority for our country. Since 2011, we've been implementing the concept for early childhood development and early intervention for future academic performance in school. Then we developed the national concept for pediatrics and early intervention, which was further elaborated in the National Action Plan. We had the National Program for Nutrition with plan of actions around that. We had the National Strategy for Early Childhood Development and the plan of actions for 2025. So basically, I'm saying that childhood development has always been a priority. Now, a few words about the stages. We actually had several stages of implementation. With the assistance of UNICEF, we established cooperation with the ECD Center at Ankara Center with our Edgiritam distinguished professor.
What happened? I'm not. I think we're facing a technical problem. Let me see if my colleagues advise me to do now. Shall I? Oh, yeah, apparently, Dr. Maya, we lost the connection with her. So I will invite our next speaker while while the team will try to. Oh, she's back now. Yes, yes. So Dr. Maya, please, you can continue your presentation.
We also organized field monitoring, inviting experts from Ankara, and they gave rather high appraisal. This is what you heard from our distinguished Professor Elgirtem. There is also certain continuity between the pre-service training and primary healthcare. We regularly hold online meetings and training sessions talking about the stages of introducing the ECD in curriculum. This is the slide that talks about the review of the curricula of pre-service and in-service medical education for the inclusion of the issues of early childhood development for the sake of development of recommendations to ensure its compliance with international standards. I'm sorry, our expert is breaking up. There's no sound. The conclusions is that during the first, second, and third year of the School of Pediatrics, from the very first classes, our students are lectured on tasks and objectives and activities of the government in the field of healthcare protection and optimal development. As stipulated by the national programs, we're also covering the issues of assessment of physical and neuropsychological development, the nutrition and feeding issues, also talking about the biological and social risk factors, about the development specifics of mature and premature babies, and all that resulted in a number of conclusions. Like we mentioned, it's important to talk about these things from the early stages of pre-service training at the level of medical schools and medical universities. According to our estimates, the curricula contain sufficient materials for the methods of calculation and assessment of physical and psychological development. And we do that by measuring assessment and by assessing and measuring development against the WHO recommendations and classical medical approaches. During the second year of the School of Pediatrics, the ECD issues are covered with 4 hours of lecturing and 2 hours of practice. Of course, that's not sufficient, that's not a lot, but we also need to remember that we're doing that at the early stages for the students without clinical experience, and of course, we shouldn't be overwhelming them with knowledge that they cannot properly process without practical experience. Of course, the courses in pediatrics across all medical schools all have at least 1 or 2 lectures and practical classes on the issues of the development assessment and using the ECD guide. And next slide, please, for recommendations. The recommendations are to introduce the issues of ECD into the knowledge control tests for all courses and years of training. Also introduce these issues into the academic performance history of students. Also draw attention of the students to work with the ECD guide to identify at-risk children. Also introduce into the postgraduate education of the courses on ECD and basics of early intervention, and also train the faculty members for pre-service and postgraduate training. And the issues of early development, habilitation, and rehabilitation are to be introduced in the courses of pediatrics and physiotherapy for different medical schools. Since identification of deviations in development needs to be done by any medical professional who's in touch with the child, it is expedient to offer early childhood training for all medical professionals who are in touch with families and children, including neurologists and classical medical professionals. And in line with these recommendations, in 2021, we developed the system of monitoring for the evaluation of early childhood development, 36 hours and 78 hours curricula. These curricula were discussed at the level of departments, at the methodological,
the next stage, ever since March 23rd in 2021-2022 academic year, we have done weekly trainings for trainers for early childhood development. When we invited specialists from Ankara University and the Department of the Turkmen State University. In 2022-2023 academic year, we started teaching these courses, which we originally included into our curriculum. I'm talking about the monitoring for early childhood development. The early childhood development training was provided to 4 healthcare practitioners 2022-2023 academic year.
Well, since we are facing again a technical problem, the connection with Dr. Maya, I want to thank her very much for her inspiring presentation. It's excellent to know that early childhood development is already part of the curriculum of pre and postgraduate education in Turkmenistan. So congratulations for your work, and to keep our time, we are passing on to our next presenter now. So I have the pleasure to introduce you to Dr. Stefania Manetti, who is a primary care pediatrician, the president of the Pediatricians Cultural Association in Italy, and member of the National Board of Nati per Leggere in Italy. So Dr. Stefania, the floor is yours.
Thank you. Thank you very much. And for this invitation, I thank ISA and WHO and UNICEF. And it is a pleasure for me to be here. I hope you can see my slides. And I will speak briefly with you regarding essentially the training in service, but I will focalize on the pre-service training for health professionals. And speaking about health professionals, we speak about not only pediatricians. I'm a primary care pediatrician, and I work in the southern part of Italy. We're speaking also about midwives and nurses regarding the training on ECD, early child development, and nurturing care. The pre-service training, what I want to stress is that we started thinking about a training for nurturing care and ECD, and developed a training program with the Ministry of Health in Italy and with the Center for Developing Child in Trieste, and ACP, which is the National Association of Pediatrician Cultural Association. We thought about a training designed with a multidisciplinary approach because that is what happens or should happen in daily clinical practice. So it was very interesting to hear about all the previous experience which were presented, and the work that is done all over the world, I would say. And in Italy, we focalized our attention on the pre-service training because, as Dr. Weber said at the beginning, to make approach sustainable, we must work on pre-service training. And it is, I think, also in our country, a critical topic. We also have a pathway of training for in-service training for primary care pediatricians, also midwives, nurses, and neonatologists, and also other health professionals.
Dr. Stefania, could I ask you please to put in the presentation mode at the bottom?
Yes, I will do that. Sorry, but it told me that it was already in a presentation mode. You can see it now in the presentation mode? Okay,
yes, thank you so much.
Sorry for this, very sorry. Okay. So we have produced 2 different courses. You can see on the upper part of my slide the logos of the different associations who worked with us in elaborating this program, this training program. And you can see also the National Order of the Midwives in Italy, 2 different orders, one in Roman province and the other is a national one. So it was a collaborating training, which we developed in 2 different ways, in 2 different courses. The in-service, which is a 12-hour training, and the pre-service, which is a 7-hour training. With 3 modules, which I will briefly show you. The first module for both in-service and pre-service is a self-training at distance learning, which lasts about an hour. And it is not a simultaneous self-training. You can take the self-training before the other two modules at any time when you program your training. The second module is a high interaction module based on the principle of andragogy, a model, a constructivistic model of adult learning, and which is good also for in-service training. And then the module 3 is particularly stressed for the pre-service training, because after the 7 hours, the module 3 is practical situations applied to different professional settings, and with the presence of a mentorship of a trainer. It's a sort of a work on field. I will show you some examples. This is what happens in our outpatient clinic, where residents have a 3-month training coming every day with primary care pediatricians. This is an example of a pediatric training, but the same thing happens with midwives or with nurses. I brought you as an example what happens in the outpatient clinic of a pediatric primary care during a first newborn visit. Okay, here, as you can see, the trainee is solicited for observation regarding what? Well, regarding the first visit, the welcome and the communication of parents, with the aim not only of acquiring information regarding family life, but also the presence within and outside the families of other people who can help the mother or the father, and also to enhance the difficulties with a newborn. Here, the training, as I said before, is very solicited for observation. The next step during the newborn visit is the clinical evaluation with parents, shared with parents, and I'm very pleased and glad to see Ilgi Hertem, Professor Eltem here, because I would say that the GMCD tool, the growth monitoring in child development, has been a very useful tool to do this. So clinical evaluation with parents aim at sharing with parents the information during the visit and promoting the child development through this, which is a very good evidence-based tool. And the trainee is urged to become familiar with the tool. And then after these 2 steps, we have a return to parents after the visit. Here, the trainee is urged to make observations and to observe what is happening with, and we stress very much this with trainees, a positive reinforcement with families who are at disadvantaged families, so more vulnerable parents or parents that just struggle every day to get along with their life. We try to reinforce the message, and I will show you how we do this, which we give in our outpatient clinic. I omitted to tell you that pediatric primary care in Italy has a specific pediatrician, which is called the family pediatrician, who takes care of newborn starting from the first days of life up to 14 years of life or 16 years of life of this child, if it has some critical problems. And it is a public service which is offered to all children in Italy. In our training context, the use of digital devices, which I must say and underline, it has been expanded during the pandemic, has been very useful to communicate with families for positive reinforcements. So not only for online visit during the pandemic, but we're using it even after that, or even for anticipatory guidances after the first visit or just a well-child visit, in order to reinforce the message. And this, I would say, has been highly valued by the residents who were present in our outpatient clinic. They greatly appreciated also what happened between, for example, a primary care pediatrician and a midwife when we have breastfeeding problems, or a primary care pediatrician and mental health services when we detect early signs, critical signs, for example, mother depression or father depression. This triangulation was extremely appreciated by our residents. And also the concept that anticipatory guidances are very good tools to share with parents. They strengthen neurodevelopmental milestones. And also in these, the use of digital devices has been very useful, as I remarked, this reinforcement. So not only communication, written advices, always with an introduction by the pediatrician, but also the digital devices have been useful to stress these messages. And the training is involved in applying anticipatory guidances during the different milestones of development with the supervision of the tutors. So there is also a very practical part. I would conclude showing you the trainers that started this program about 2 years ago. This is the a room in the Ministry of Health, Istituto Superiore di Sanità, and these were all not only pediatricians, primary care pediatricians. You can see the one with the masks was the first course that we had during the pandemic. But here we have primary care pediatricians, midwives, we have representatives from UNICEF, we had doctorate from the mental health institutes, we have neonatologists, some educators, psychologists, and nurses. So we will go on with this pathway. And the other thing I would like to say in conclusion is that the academic and the academy in Italy have shown the same problems that I heard before when I heard the presentations of Professor Ilghi, and also the presentation that preceded mine, because there's great need to get inside the curriculum of primary care pediatrics. And it is a critical point, and we're trying to work on this, but we also have problems. And now we are in contact with 4 academies in Italy, and we're trying to get somehow raise their awareness regarding this. So I thank you very much for your invitation. Thank you.
Thank you so much. Thank you so much, Dr. Stefania, for this inspiring presentation, for sharing with us this quite interesting program that you run in Italy that addresses ECD and nurturing care in both pre and in-service training. Thank you so much. So our next speaker is Dr. Soloci Kathleen, who is assistant professor at the Department of Family Care Methodology, Faculty of Health Science, Simil Wells University, Budapest in Hungary. Dr. Kathleen, the floor is yours.
Thank you very much for the introduction, and also thank you very much to provide me this opportunity to introduce the Hungarian health visitor system and education. The health visitor system in Hungary is more than 100 years old, and it's a Hungarian, we can consider it as a unique system in the European Union due to its comprehensive and community family-based approach to healthcare. Health visitors, or in Hungarian word, védőnő, they are healthcare professionals, preventive professionals who provide primary healthcare services to individuals and families, focusing mostly on maternal and child health. So they are preventive professionals who takes home visits regularly from the very beginning of the pregnancy until the child reaches 6 years, 7 years of age, so school age. Due to this proactive approach, they can discover and identify not only health issues, problems, but also social issues as well in the earliest stage possible. So that's why we consider this system unique. And then let's see where they can work. Health visitors, they can district health visitors, school, hospital health visitors, and they can work in family planning centrums. The majority of health visitors are working as district health visitors. In the primary care sector, they have a district, and their main responsibilities are supporting women's health, prenatal care, postpartum care, and they focus not only physical assessments, but also supporting parental skills, supporting breastfeeding, mental health. They are responsible for infant care and child health care until they reaches the school age. They contribute to vaccination program, and they take home visits regularly. And besides the home visits, they perform age-related screenings in their offices. They assess not only physical development, but social, emotional, mental development of children. Of course, if they identify any high-risk cases, social high-risk cases such as neglect or abuse, then they need to report it to the social sector as well. School health visitors are working in schools, educational institutes, who are responsible for also age-related screenings, contribute to vaccination program, and they are responsible for health education. Hospital health visitors are working in hospitals, postpartum departments and newborn departments mostly. They organize prenatal classes, and also they educate parents on basic infant care methods, including breastfeeding techniques, nutrition advices, personal hygiene, sleeping habits, and so on. And they have a crucial role in communicating with the primary care sector, because they need to report every delivery. They send an official notification for the district health visitors and pediatricians after every newborn. The fourth one is health visitors in the family planning centrums, who are responsible for positive and negative family planning as well, including crisis counseling for those who would like to interrupt their unplanned pregnancies. Especially the district health visitor and school health visitors are working with their patients long-term for years. That's why the close relationship, developing a trustful relationship is really important in their cases. In the hierarchy, we have the National Healthcare Service Centrum, which is a background institute of the Ministry of Interior, and they have a house visitor department. And this is the regulatory level. So between the regulatory level and the house visitor, the practice level, we have the mentor health visitors in regional hospitals, who are kind of a bridge between these two levels, who provide the current guidelines, protocols, regulations, changes, news for the health visitors, and also collect information, data, and report it to the ministry if it's necessary. So as you can see, it's kind of a really well-structured system. So if there is any problem, any changes, then the system can react really fast. As I mentioned, they take home visits regularly, which is we truly believe that home visits are really important, because health visitors providing counseling, mostly health-related topics, and home visits can provide this intimate environment for these more intimate topics to discuss. We can also observe the environment and the child's behavior in their own environment. So that's why we think that home visits are really important, and which is also important that the house visitor service is obligatory for all of the patients, which is regulated by the law. And in this slide, you can see that how often we should offer our visits. These are the minimum numbers what we need to offer for the patients. For example, pregnant women, we visit them at least 4 times during their pregnancy. The first visit usually after the first meeting, they usually apply for the service in the first trimester, and then we visit them at home, of course, check the environment and talk about more intimate topics. And usually the last visit is right before the delivery, to prepare for the delivery. Postpartum women and newborns, we visit them within 48 hours after their discharge from the hospital. So the hospital house visitors send the official notification for the district house visitor, who visit the patients kind of immediately. Only exception if it's a national holiday or a weekend. And then after, we visit them once in a week in the first 6 weeks. So it's really often. In infants, we visit them monthly, toddlers every 2nd month, and children, depends on they are in community or not, 2 or 5 times in a year. And also we can visit those who, however, reaches school age but do not attend an educational institution, around twice in a year. For those who require enhanced care because of health or social issues or both, then we provide more regular visits and visits, of course. Besides the home visits, we have the age-related screenings, as I mentioned, in the house visitor office. You can see that this is also quite regularly, and these screenings we assess the physical, mental, social, emotional development of children, which is based on other examinations, observations, and also the parents' observation, using a special structured questionnaire dedicated for parents. And shortly about the health visitor education. In Hungary, we have 6 universities who provide house visitor program. This is a bachelor level program with 8 semesters, and one university is the Semmelweis University, where we have the highest number of students every year. In the first 4 semesters, they have basic subjects such as anatomy, biology, and then we start with the specializations, and also they have field practices and clinical practices. So they learn obstetrics and gynecology. They have clinical practice in the third semester. They continue the obstetrics, and they learn children's development, neonatology, pediatrics, and they have clinical practice. And from the 5th semester, they have house visitor field practices. They continue neonatology, pediatrics, children development, female health care and prenatal care, preventive family care, public health methodology, including school health nursing, and they have also clinical practices and house visitor field practices. And the last semester is 100% field practice, and which is really important that this education, this practical education, is organized by one health visitor, one student combination, which we consider really important to focus on one student 100%. So this was about the education, and I think my time is already finished. So thank you very much for your attention, and these are my contact email if you have any question later. Thank you.
Thank you so much, Dr. Katalin, for sharing with us the your experience in the health visitor system from Hungary. Thank you so much. So yes, please take a look in the chat. There is a question for you. Okay, our final presenter is Dr. Karin Whittaker, Education and Workforce Lead at the Institute of Health Visiting and Visiting Fellow at the School of Nursing, University of Central Lancashire in England. Dr. Karin will address another important topic, which is supervision. Please, the floor is yours.
Thank you very much, Alexandra, and thank you to all the organisers for today. We've listened to some tremendous speakers. I'm speaking from the UK, where we also have a model of health visiting, which has been in operation now for well over 150 years. So also, like Hungary, has a long history. Health visiting in the UK is the primary source of home visiting to support early child development. And health visitors here are all required to be registered nurses. Supervision is a form of support and professional development which is offered in service. And it is something student health visitors would be introduced to whilst they are within training. The word supervision has many different meanings, but when we look at the different definitions, there are a few features that come together collectively. First of all, supervision always involves a supervisor and a supervisee, and they are involved in reflecting on practice. Another point is that it's important that the supervisor is skilled in listening and guiding and asking questions in a particular way that supports the development of the person being supervised. Thirdly, it takes in the opportunity to give really good attention on the practice situation of the home visitor, which means that it's indicating to the people providing the service, the home visitors, that the organisation has a real serious concern about the quality of the service being provided. This means it's a crucial and important part of professional development, and if done correctly and with good attention, it offers a great means of supporting the resilience of practitioners through that collaborative working between the supervisor and the supervisee. So I have a quick slide here just to show you an image and to give you that question, what do you see? Because that is one of the questions that the supervisor must ask themselves. What do they see when they start their relationship with the person they're supervising? And we'll return to this later. So why is supervision important? Well, it's important at three different levels. Firstly, the level of the organisation, because as I said before, it communicates a commitment and demonstrates a high commitment to the quality of the services that are being provided to babies, children and families. But it also communicates to the employees a sense of duty of care, so an interest and a concern for their well-being on behalf of the communities being provided for. With regards to supervisors at that level, it's an opportunity for people to review colleagues' performance and their professional needs. It's an opportunity to invest in knowledge development, skill development, and importantly, it's an opportunity to demonstrate a culture of continuous learning and commitment to quality improvements. And then at the level of the home visitor, of course, it means it encourages an enhancement of professional practice, an opportunity to review their practice, and also for them, the home visitor, to be thinking about their own learning needs and develop action plans that can respond to those learning needs. And then ultimately, a means of managing stress. But there are three important things to note, or two important things to note with respect to supervision. And as I started out by suggesting, the word can mean different things to different people. So, for example, it might be taken to be understood that it's about directing the work of others, whereas other people might immediately realize that it's about guiding the practices and work of others as opposed to directing. And thirdly, some may just approach it simply as a means of restoring the practices and well-being in other people. So it's important that there is some level of preparation and coming together in defining what supervision means within the organization and by the supervisors. Because if not delivered appropriately, and for example, if it's used as a means of highlighting where there are problems and therefore assigning blame, of course, it could result in punitive action and have exactly the opposite intention of what it's meant to be there for. So to succeed, supervision needs organizational commitment. And through that, there needs to be supervisors that have been adequately trained, and indeed supervisees who have had time to be introduced to the process and the materials. And this has been particularly looked at in a most recent systematic review by O'Neill, published just last year. Often the model that's used when developing supervision has three parts to it. A normative part, which is concerned with the organizational's responsibilities, a formative part, which is concerned with the development of staff, and the restorative part, which is concerned with the emotional well-being of staff. And what runs through all those three parts is reflective practice. So reflection is a critical ingredient to effective supervision. And it's through the process of reflective practice that the expertise in the supervisor, who is skilled at listening and asking important questions and carefully worded questions, that the person being supervised has the opportunity to describe and review particular experiences, the opportunity together to start making sense of what happened in those experiences, and then working out what has been particularly learned and how to move forward, create a plan for what happens next. And I just illustrate here a particular model developed by Gibbs, which is well used, tried and tested, which has lists there the different stages if using this as a way of writing down those experiences and creating a record to really consider experience and learning. So ultimately, the benefits of supervision that have been identified through a number of different research studies across nursing, midwifery and other helping practices. Firstly, that's the sense of being able to make better decisions when working with families. That was a key finding in a number of studies. Also, though, the ability to maintain better quality of service provision through enhancing the consistency of practice. Thirdly, as already mentioned a few times, the opportunity to support staff when they're feeling stressed. And this is particularly helpful when thinking about the problem of retaining staff and limiting the sense of burnout that people can get when feeling very immersed in dealing with a range of challenges when working closely with families. And of course, providing a safe space to look at different experiences. So ultimately, supervision contributes to lifelong learning. And it may be described as a way, if done regularly, an opportunity to peel off old ideas and, of course, stimulate fresh thinking. So all in all, clinical supervision, when done properly, is a means of guided reflection on practice. It offers an opportunity to share experiences, whether that be in a one-to-one relationship or in a group setting through group supervision. It's a chance to acknowledge the strengths that practitioners have and at the same time look at areas of development. And of course, through all of that, there's a commitment to strengthening practice and quality. So we return to the picture. And as you can see, the picture wasn't of a local town. It was actually a model of a town. That's me sat in front of them, the buildings at Legoland. And I put it there really because it's the point that supervision helps us see the bigger picture. Thank you very much. And this has been a whistle-stop tour for a huge topic, but my email address is there for anybody who wants to make contact with further questions. Thank you. And some further reading.
Thank you so much, Dr. Karins. Is always very inspiring. Listen to your presentations. Well, now we are unfortunately running a bit late, but if I could ask to our presenters just to say very quickly a few words on one takeaway from your presentation to our audience, what would that be? Dr. Ilgi?
I'd say don't be late in starting pre-service training in this field, and train your trainers perfectly.
Thank you so much. Dr. Stefania?
I would say that pre-service training is extremely important because it lays the foundation of what happens after when they start working in primary care or everywhere else. And it is extremely important advocacy action for this, which must come from everyone, everybody, all health professionals, but even parents. Anything we can do for this is extremely important, I think. Thank you.
Thank you so much. Dr. Karen?
I would say to remember that learning continues, and even after qualification, it's important that the workforces continue to help to be provided with opportunities to continue to learn, because that's what keeps us alive and interested in what we do.
Excellent. Thank you, Dr. Kathleen.
Thank you. I would say that close relationship with our patients and regular relationship with them, home visits, especially during home visits, can provide us the opportunity to discover problems as early as possible. So home visits provide us more benefits than we think. Thank you.
Thank you so much. Dr. Maya? Is Dr. Maya? No, she's not with us. Thank you so much. So now I have the pleasure to invite Ms. Alexandra Jovic, the Early Childhood Development Specialist at UNICEF Regional Office for Europe and Central Asia, for the closing remarks.
Thanks a lot, Alexandra. Thanks a lot. Thanks a lot to all the presenters. I truly feel humbled every time at these webinars when listening how much amazing work has happened across countries, and you are the pioneers of this work, and I hope that you take the pride of taking the light and showing that changes are possible, and that some countries have gone ahead of the curve, and that there are pointers for all of us to follow. It's difficult to summarize, and because we heard examples of pre and in-service trainings of doctors and nurses, allied professionals, and although great examples are laid on the table, it is clear to all of us that a lot of work remains to be done in order to integrate basic training into all standard university curriculum of medical schools, and basic studies, as well as specialization courses. What we heard from Ilge, I think we should repeat in all the occasions when it is possible, and it is that evidence shows that 15% of children will have developmental delays, and 30% of them will have developmental risks, which, if acted upon timely, can be really dismissed and children return back to the optimal developmental trajectory. It is the huge responsibility for the health system if health system is truly familiar with this data. It creates also a huge burden for the health system to respond to all the needs, particularly if we hear and understand that majority of this workload and cases and needs should be addressed at the primary healthcare level. So healthcare professionals working at the primary healthcare level should have ideally all these skills and competencies. Currently, we are investing a lot in the in-service training, and you have heard that UNICEF is really present across countries and trying with our programming to fill the gap. But nobody will have sufficient resources to fill the gap endlessly because the burden is increasing and we are not addressing the bottleneck where it exists at the pre-service training. And we have heard that health professionals do require training, that this is not intuitive knowledge, that the training on how to establish trusting relationship with the family, how to assess risks and strengths of children and family, how to provide empowering guidance and link with other services within health system, but also with other sectors are needed, and they need to come through the planned training. Many of these skills and competencies we have to know are not unique to early years, are not unique to the support to nurturing care, and would benefit overall effectiveness of health professionals in providing health care and support for behavior change and well-being and health. What we have heard as well is that examples show that 7 to 12 hours of training would be sufficient to cover the basics if integrated into the pre-service training curriculum. And that these hours are marginal to the overall curriculum content. What puts us again, and gives us this important task to continue with advocacy, primarily with academic institutions. Also, a huge thank to our colleagues from the European Academy of Pediatricians who are today with us. Pediatric associations, we should all be at the forefront of continuing to advocate for the examples that are now living, that are showing benefits across countries to become part of the reality across. We have heard also, what are the curriculums that are in place, and we will take at least what is in our power to try to disseminate these examples so that, again, champions and professionals from different countries have something very concrete and can try to see what can be applicable in their particular cases. Case of Hungary is really amazing. The child development is integrated fully into the training of the home visiting nurses, and a very rich package of services provided to young children and families. I'm repeating at the end what some of you have said, that again, we are strongly advocating for the changes in the pre-service training, but we are fully aware that there should be a continuum. Also continuing professional development through in-service training and strengthening it with the supportive supervision. I'm using opportunity also to remind you that linked to the health systems for ECD, we have the learning platform called Learn ECD, in which over 20-30 modules covering different competencies related to child development is available, and my colleagues will paste it in the chat. Currently, we are increasing the number of languages in which these courses can be taken at your own self-paced learning, and please be free to promote it in your country and share and get back to us if you would like them to be available in your languages. With a lot of thanks to all the participants that stayed with us until the end, we will try to also use the platform to put, to publish new blogs with some of the experiences that have been shared today. You will have access to all the presentations, and we will continue with this work, inspired also by your attention and interest in these webinars. And we invite you to subscribe to the mailing list, through which you will continue to receive invitations and information on what are the new resources published at the platform. Thanks a lot to all.